Good afternoon, everyone. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the session today. Thank you for joining us on this ECHO session for the Comunidad Long COVID. And I would like to start by providing a brief overview of the comprehensive long COVID care for underserved communities. This is innovative delivery and dissemination model project, also known as a Comunidad. Across the country, long COVID specialty clinics have emerged to meet the needs of people experiencing lingering effects after COVID-19. And while some offer multidisciplinary care, access to those services remains limited, especially for those in rural and medical underserved areas. At the UT Health San Antonio, our post-COVID-19 recovery clinics serve both San Antonio, which is the seventh largest city in the United States, and a broad, larger regional rural area in South Texas with predominantly Hispanic and Latino population. These community face significant health disparities and barriers to care and information for long COVID. To address those challenges, the Comunidad Project, which is a 5-year initiative funded by Agency of Healthcare Research and Quality, and the Comunidad Long COVID ECHO seeks to improve and expand the long COVID care through innovative and sustainable models in the region and beyond. Now, for those that are new for the ECHO platform, ECHO stands for Extension for Community Healthcare Outcomes, and it serves as a virtual telementoring platform, especially designed to create connections between communities and subject matter experts. These sessions start with the introductions, and then we have a didactics, then we have a case presentation, and then we invite everyone to participate in discussion. During the case discussion, members of our community will present a real-life patient case to address their healthcare needs. So therefore, to ensure privacy, no personal health information is allowed to at any point be shared in these sessions. Now, if you're interested in present a case, please contact us, or please contact the ECHO team to present a case if you are interested in doing so. Just a few housekeeping reminders. Please enter your name and your affiliation in an email in the chat. This is for our attendance records. If you have any issue or problem with the connection, please contact the IT person to resolve that situation. And we invite you to join us by video, particularly in the discussion part of the session. So if you are comfortable and you feel fine, please join us in the discussion part by joining us by video. ECHO is all teach, all learn environment. We encourage you to participate in our conversation today by sharing your comments, your questions through the chat or doing in the video. I would like to continue with an introduction. So I would like to start introducing our team and also the case presenter and didactics presenter. So I would like to start by Dr. DeGrari.
Hello, everybody. My name is Roy Tegrarian. I'm a psychologist on the team, and I provide psychotherapy to patients suffering from long COVID.
Thank you very much for your support. I would like to continue with Dr. D. Erowskin, is the didactics presenter for today. Thank you so much.
Good afternoon, everyone. I'm Gabriel De Erowskin. I'm a neurologist at the Glenn Biggs Institute for Neurodegenerative Disorders. And the reason I'm talking to you today is because I do research in long-term neurological sequelae of COVID.
Thank you very much. As he's going to be present at the didactics for today. And if you're interested in another topic, please let us know and we can always address those comments. And then I would like to continue with Dr. Broad. He is the case presenter for today.
Hi all, Mike Broad. I'm a general internist here at UT Health Austin, and I am medical director of our post-COVID program here.
Thank you very much. As a part of our hub team, we have Dr. Lisa Capella.
Hi, everyone. I'm Lisa Smith-Kilpla. I'm one of the PIs on the long COVID grant that is how we're building out this ECHO. So thank you all so much for being here.
Thank you very much. I know Dr. Gutierrez Verduzco is going to join us in a second. But for everyone that just joined us, please enter your name and your affiliation in the chat. This is for our attendance records. And just would like to finish from my end. And I want just to mention that ECHO is all teach, all learn environment. And we encourage to participate in our conversation today. So I would like to then start with Dr. D. Erowski, so that the didactic is presented. Thank you so much. Doctor, I think, Dr. Oraskin, I think you are muted.
Yes, I was.
Thank you so much.
All right, so I have your names list in view, and even though we are remotely connected, I'd like to make this as close as a conversation as possible. I don't have that many slides, and I would rather have you ask me questions about any of these pieces of information that I'm going to be sharing with you as I go along, rather than saving all the questions for the end. So if you have a question, just raise your electronic hand and I will stop to address it. With that, you have my first slide there. I like to talk with you today about the cognitive sequelae of COVID-19. I think this needs a bit of context, even though I'm talking to people who are interested and familiar with this. And we are all very familiar with this phenomenon, the phenomenon of the infection lethality, which was very high in the first 2 years of the pandemic and then faded away rather quickly. But the reason we are here today is because that doesn't mean that all of the consequences of the infection faded equally. Part of the reason for this is actually illustrated in this slide. What this shows is the variations, genetic variations of the virus as time developed from the very beginning of the pandemic in late 2019. The virus, as you can see, each of one of those dots is a different genetic variant, evolved rather quickly and rather broadly, which means that the clinical presentation of these viruses or these infections also changed over time. That explains in part the reduced lethality of the newer versions, may also explain why the consequences, the long-term consequences of the virus appear to be changing as we move along, but not changing enough that the burden has completely gone away. The way the Centers for Disease Control try to estimate the burden of disease is not just by the deaths, which are the tip of the iceberg or the top of the pyramid in this diagram that they provide to support the data I'm going to show you in the following slide. But you can see that there are a number of illnesses that don't get transformed into clinical visits into an outpatient clinic, are much less or much fewer of them are actual hospitalizations. And only, as I mentioned again, the tip of the iceberg is represented by deaths. Nonetheless, data for last year show that the Centers for Disease Control continues to track this information quite actively. And the number of illnesses, admissions, and hospital visits is actually quite large. It remains a very, very high number, even though the deaths are a tiny fraction of what they were in the beginning. So what are these visits about? I mean, you're all very familiar with the more common physical presentations of long COVID, particularly the so-called myalgic encephalopathy type of presentations, meaning those patients that present with fatigue, pain. The pain can have any number of locations in the body, can be headaches, can be physical joint pain, can be moving joint pain, can be muscle aches, and so on. A fraction of them also have, as you know, respiratory or cardiac symptoms that accompany these changes, and also a small fraction has autonomic instability. I'm pretty sure all of those things have been covered by others in these meetings, and so I'm not going to dwell on any of them. I'm interested in sharing with you today the focus of our research, which is what happens to brain function in patients who have been exposed to the infection at some point and continue to manifest problems on one kind or another. This is actually data that we published, I think it was by now a year ago almost, looking at the profile of cognitive complaints or cognitive deficits in a very large international analysis. These are actually cohorts from 8 different countries, including countries in all continents. So we had a sample from India, a sample from Russia, 2 samples from South America, and so on, a couple from Europe. And across the board, you see that people who were exposed to COVID-19 remain abnormal, if you will, on cognitive testing. Now, the catch here is that it doesn't, so these are the meta-analytic data on the left here in this panel, showing you that this is clearly true across the samples for this. Actually, this particular panel is for the trail milking test, which is a way to measure, for those who are not familiar with it, executive function, meaning the ability of the person to arrange a sequence of events in order such that they achieve a particular outcome. A trivial example of that would be putting together a simple recipe in the kitchen so that you can come up with a soup. But the trail making test is a bit more formalized and mechanical than that, and asks people to sequence letters and numbers in the proper order. But even a simple task like that, these folks that have been exposed to COVID, on average, and this is again across the board, appear to have significant problems with. They also have trouble with memory recall and memory recognition. Now, this is not true of everybody. And when we dissected this analysis across the board, what we found is that there were several determinants, so we will try to go through them, but the single major determinant of what type of cognitive profile deficit you had, or you were likely to have when you have long COVID, was actually rather dramatically different in people older than 59 and a half years of age, so 60 and over, versus younger than that age. Older individuals that had been exposed to COVID, and this is again, let me go back to the original slides and qualify what I'm saying. This is true of people who were exposed to COVID during the first year and a half of the pandemic, so up to December of 2021. Younger individuals had a tendency to have either no abnormal cognitive testing or have only attentional and concentration deficits, more consistent with the so-called myalgic encephalopathy or chronic fatigue syndrome type of presentations, whereas individuals that have been exposed to the virus after the age of 60 or at the age of 60 and older tended to have a profile that was more consistent with what in a visit, in a clinical visit, without knowing that the person had been exposed to COVID, we would have thought of as the earliest manifestations of Alzheimer's disease. They had mild language impairment, significant memory recall trouble, and occasionally, as I mentioned, executive dysfunction, although that was mixed because people who had significant impairment in concentration also had abnormalities on the trail making test. But the point is, when you separate it by age, the bulk of the effect on cognition appeared to come from the older folks. This is not something that is very surprising, but even though independently of how severe the infection had been, you were, if you're older, equally likely to have, or almost equally likely to have some degree of cognitive impairment. The severity of the infection itself at the time of the admission or at the time of the clinical consultation in 2020, 2021 also was a strong predictor of severity of cognitive impairment. This is perhaps not so much of a surprise for those of you who are familiar with neurological disorders, and particularly degenerative disorders of the brain, but was indeed one of the reasons why we started doing this work very early in 2020. And it is that folks that were exposed to the virus on the initial few rounds of the pandemic very, very commonly showed severe loss of the sense of smell. Again, for those of you who are familiar with the clinical presentations of patients with neurodegenerative diseases, this is actually one of the hallmarks of Parkinson's disease, Lewy body disease, Alzheimer's disease, and even frontotemporal dementia. People who have neurodegenerative disorders very commonly also have anosmia. So this prominent effect of the virus early on was what drove our attention towards the possibility that there may be such a thing as a long COVID with neurodegenerative manifestations, and it was the initial support for the work that we began doing in collecting this data. And again, it remains true that when you look at the severity of the smell impairment, chronic in this case, because it's almost a year after the infection, the severity of the smell loss or the ability of detecting and dissecting, identifying smells loss, that also predicts the severity of the cognitive impairment quite effectively. The statistical predictor is very, very strong. And the ratio for severe impairment when you have anosmia is almost twofold. Meaning, if you have anosmia, you're twice as likely to have cognitive impairment if you're, particularly if you're over the age of 60. Actually, that number is bigger when you're over 60. So, is that all there is? In other words, all we have is functional changes. I know that one of the hallmarks, if you will, of chronic fatigue syndrome and myalgic encephalopathy and syndromes of that nature is that they're often thought of as functional, meaning that they don't have a correlate in brain abnormalities when you look at their cognition compared to the general population or compared to other appropriate controls. In the case of long COVID, it turns out that this is not true. The data I'm showing you here, and I will explain in a second, are data from our sample from South America. This is a little over 1,000 participants analyzing this slide. But very, very similar findings were reported by the UK Biobank study. This is actually a population-wide study in the United Kingdom that collects hospital-based data for a number of voluntary participants over time. And the study had begun before COVID, so they had a way to compare brain MRI volumes in folks that were exposed to the COVID before and after, which was a rather unique opportunity, which in this case we don't have. And I'll explain this slide in just a second. But the UK Biobank data showed quite clearly that folks that were exposed to COVID and had what they called in that manuscript, in that publication, dementia-like symptoms, were also much more likely to have volume loss in key brain structures associated with memory function and memory organization, the hippocampus, the amygdala, and so on. Well, when we looked at our data set, what we did was actually compare people that were exposed to the infection versus people who were not exposed to the infection, and then organize, if you will, or stratify the people who were exposed by the severity of the cognitive impairment. And what you are seeing here, those z-values are standard deviations away from the mean of the controls as your cognitive impairment becomes more severe. And this was made volume pixel-wise, meaning, or voxel-wise, as it is called in MRI, meaning that we were not comparing structures, we were comparing each individual bit of the brain, if you will, person to person, so that allows us to do this in a very unbiased fashion. These are numbers that reflect the correlation between cognitive impairment and volume loss in people who had been exposed or were exposed to COVID after the age of 60. And you can see quite clearly that the brain structures that you would expect to be the ones that were reported by the UK Biobank, meaning the middle of the temporal lobe, so the hippocampus, the amygdala, the base of the temporal lobe, etc., were the entorhinal cortex, were markedly shrunk, markedly decreased in volume. What we found that was a bit of a surprise is that there were also structures associated with language in the left frontal lobe that were also shrunk in our sample. And more remarkably still, there were very, very profound changes in the midbrain. Now, that's not associated with Alzheimer's disease, typically. So what this means is that even though, as I mentioned at the when we were discussing the data from the pooled study from the international cohorts, in people who were exposed to COVID after the age of 60, the clinical presentation may very much look like, on average, what you would expect to see in a person with early Alzheimer's disease. Their brain changes extend beyond what you would expect in that population. So we have some changes that are consistent with Alzheimer's, but then some things that are novel and that are caused by or seem to have been caused by COVID, and we would not have expected. So do these changes have a clinical correlate? And this is actually my last slide, and then we can have a conversation about all of this. And the answer is yes. What we found is that there is actually, before I get into that, I apologize. I forgot that I had data on the genetics. We have, and I'm not going to spend any length of time talking about this, but we have been digging into the possible explanation for these changes. And we found that there is a genetic predisposition in the participants or in the folks that have both the cognitive impairment and the brain atrophy, selective brain atrophy in the critical structures. There is a genetic interaction such that people who were exposed are more likely to share genetic information as well. These are some of the genes we're looking at this point. Again, we don't have the time to dwell into that. But one of them that's interesting is we looked at the ApoE. For again, those of you who are not that familiar with the literature in dementia, ApoE4, just like it is a risk factor for cardiovascular disease, it's a very significant risk factor for Alzheimer's disease. Turns out that having an ApoE4 carrier status in this population protects against the effect of the infection. This is something that we can discuss more at length in the question and answer session. But so that it doesn't sound completely crazy, it's actually, there is very good information on East Africa pointing out to the fact that ApoE4 may have been selected because it is a protecting factor against some forms of infection, particularly malaria in that population. So it may well be that what ApoE is doing here is not deleting the effect of ApoE on risk, in fact, that persists in the controls, but making that the opposite effect in people who were exposed to the virus. And that's a rather interesting biological hint that we need to pursue further. But let me go back to the issue of the midbrain atrophy. This is just one case example of one of our patients. This is a 58-year-old woman that was exposed to COVID, was completely normal up to then, and developed a rather rapid syndrome of progressive supranuclear palsy. For those of you who are not familiar, that means that she had significant eye movement abnormalities, had trouble moving up and down the eyes, developed unprovoked falls, in part because of that. They couldn't, they cannot look down, and so they have a tendency to trip and fall over. They also lose part of their postural reflexes, and they have Parkinsonism without tremor. That syndrome that is typically known as progressive supranuclear palsy and is associated with sporadic cases with tau pathology is actually rather common. And in post-COVID, and we have found that although this is still unpublished data, but we have found that the risk of having progressive supranuclear palsy after the exposure to COVID is actually a few hundred times higher than in the general population. This is a rather rare syndrome, and it's become rather common in the long COVID clinic. Okay, so summarizing, what I have tried to show you is that long COVID is really not a historical phenomenon. It's actually a rather live and troublesome problem for those of us who are seeing these patients regularly. And the manifestations that are associated with the infection in the population over the age of 60 is quite different from what we see in younger adults after COVID, because it includes in the older population neurodegenerative manifestations that are consistent with an Alzheimer's disease-like or dementia-like syndrome, as the UK publication called it, plus a movement disorder impairment, which appears to be rather unique to this population, that mimics progressive supranuclear palsy, in which we're particularly interested. Last but not least, I want to emphasize the fact that we are looking at clinical predictors of this that can be used broadly, such as ApoE for status, which in this particular case appears to go in the opposite direction. We're normally used to use it as a predictor of increased risk of stroke and Alzheimer's. This appears to be a protective factor in this particular population. But we need to dissect that much further, and the results of that hopefully will come out in the next year or so. With that, I'll stop, and I would love to hear questions or comments on any of this.
Thank you very much, Dr. Raskin, for this very, very interesting presentation. I have been learning a lot. Is there any question from the audience in regards to this presentation? You can even unmute yourself, or you can post it in the chat.
Go for it.
Yeah, maybe put you on the spot a little bit, but I get asked this question all the time in clinic. Doctor, am I going to develop dementia? I know it is too early to tell, but we are seeing signs of brain volume loss for patients who do not fully recover, continuing to have the neurocognitive impairment. How are you counseling them about their potential long-term risk?
If they are young, my answer is no, flat out. I mean, we don't have any evidence that in people over under the age of 55, for sure, any of these things are chronic or developing or progressive. In the older folks, I tend to be a bit more conservative in my answer. I tend to answer I don't know, which is a true answer. We know that the changes are real, the changes are present. We don't know if they're irreversible. And so I tell them that. I tell them the jury's still out, and you know, the usual general brain health recommendations come into play. I also tell them that we are going to try to exclude treatable conditions, so we look for those, including Alzheimer's disease, which, with all of the caveats that belong to that statement, it is a treatable condition now. And so we actually do search for evidence of Alzheimer's in spinal fluid, and if there is actually pertinent changes in amyloid, we do discuss treatment. Even though, as I showed you, I'm not convinced that this actually is Alzheimer's. But since it is a treatable condition, we cannot exclude it off the bat. The other interesting feature, which I'm sure you all are much more familiar than I am with treating daily, is that oftentimes these folks do have persistent inflammatory markers in peripheral blood. So they have D-dimer, they have decreased prostaglandins, they have, you name it, decreased complement, and they have persistent nucleocapsid antibodies. And so that's the other question that Monica and I deal with on all the patients that we share is that do you treat that and how? And yeah.
Dr. De Oreskin, there is two questions, but I think that there is one is connected with the question that was already mentioned is in terms of people asking, am I gonna develop this condition? Do you offer any preventive measure strategies to help decrease the chances of developing Alzheimer or dementia?
The ones that we were just discussing, I mean, in general, what's so-called people call brain health prevention strategies, which are so common sense as to be almost ridiculous when we say them, but actually they work. We know that 40% of the risk of Alzheimer's is decreased by doing these things, and those are daily physical activity, maintaining a healthy/Mediterranean diet, and doing regular social and intellectual engagement. So those three things combined, plus controlling your high blood pressure, reduce the risk of developing Alzheimer's by 42%. So it's not trivial. And I do discuss those things with them.
With them. Very good. Thank you so much for give us that answer. And there is another question. What age do you mean with the older folks? What age do you mean?
Well, I hope I said it a few times, but bears repeating. The cutoff point on the large international study, we looked at a little over 3,000 patients, was 59 and a half. That's the empirical cutoff point, meaning if you're a 60 or older, you have much higher risk. Now, it so happens also that in our longitudinal NIH funded study, we had picked up that age. It actually happened to be luck, I have to admit. We did not decide 60 on empirical basis. We did it because that's the age at which risk of Alzheimer's starts to go up. But it turned out to be a lucky guess because on the empirical analysis, that was exactly the age that came up, 59 and a half.
Okay, thank you. Thank you very much. Is there another question, another comment? I don't see anything in the chat, but if does someone want to unmute yourself and ask question? If not questions now, we can think in those maybe later, but thank you so much. It's a very, very good presentation. Very, very good information. So with that, I would like to see if we can move to now the case presentation. Dr. Brock, whenever you're ready, please walk us through the case.
Yeah, thank you so much, everyone. I want to present a patient I've known for, wow, almost 4 years now. But this is a 31-year-old woman. She has a pre-existing history of complex PTSD and generalized anxiety disorder with some hyperflexibility, who first developed her first COVID-19 infection in December of 2021. And following that acute illness, developed profound fatigue, neurocognitive dysfunction, brain fog, post-exertional malaise, and autonomic symptoms. She also noticed after that time that a lot of her mental health symptomatology, anxiety, and sensitivity to external sensation was much worse, and at the same time developed new diffuse neuropathic pain, which she described as kind of prickly burning pain throughout her body. She has had a very extensive workup that has been most notable for a initial ANA and a 1 to 320 titer that did not have any reflex ENA positivity. She was evaluated by a rheumatologist who did not think she met any criteria for a known rheumatologic or autoimmune disorder. We have done more extended autoimmune panels, including some paraneoplastic dysautonomia or ganglioside antibody testing, which were also normal. She was found to have POTS, both on tilt table and home testing, and we performed a skin biopsy that demonstrated small fiber neuropathy with reduced epidermal nerve fiber density in the leg and calf. No sweat glands were identified, but given the context, we interpret that as both sensory and autonomic small fiber neuropathy. She has been very active in the long COVID advocacy community and quite locked into both research and advocacy opportunities. She participated in Recover Vital, randomized to Paxlovid or placebo, and had no benefit, although she has not been unblinded for what she received. She then went on to participate in the Recover Autonomic study, randomized to either IVIG or placebo, but was having a lot of difficulty tolerating the infusions, and so was removed from that study, which she would describe against her will, with some mild symptom improvement on either placebo or IVIG. She still remains unblinded. She, unfortunately, despite time and pretty intensive management, trying both symptomatic treatment and experimental treatments, has had progressively worsening symptoms, especially over the last year. She has had 3 reinfections. Each of these have exacerbated her underlying symptoms. She reports new, which she describes as mast cell activation syndrome symptoms, new allergies, GI dysfunction, although she has never had an elevated tryptase level and has not empirically responded to more of the traditional antihistamine regimen. But certainly she's had a little bit more of a progressive course and has been very sensitive to medications, more in that MCAS-like phenotype, which has made it difficult to trial different symptomatic meds or really recommend more experimental ones, although she did have a pretty significant response to EECP, but has not been able to afford going back to that. So she's complicated. Currently on low-dose naltrexone at a very, very low dose, 0.1 milligrams, because that's the maximum she's been able to tolerate. Her neurologist has been titrating pyridostigmine and midodrine for her POTS symptoms. She was unable to tolerate beta blockers. And she is not currently on any psychotropic medication because she has not been able to tolerate that. She just remains on the gabapentin at night for the neuropathic pain. Let me stop there to see if there's any questions about the case.
Thank you very much. Is there any question from the audience in this case?
I have a quick one.
Yes.
Peripheral markers, I mean, it's very thorough workup. Congratulations. But D-dimer, ferritin, CRP, complement, any of those?
All have been normal. She's seen quite a few providers, but yes, all the peripheral inflammatory markers just positive for that ANA. We've done ANCA, complement, all normal. Ferritin normal. She does have endometriosis, and that has been her, like I think the research indicates it is sometimes her menstrual cycle leads to post-exertional malaise, and then and she is having more severe menstrual cycles independently long COVID and did undergo endometrial surgery about 6 months ago, but has had no significant improvement in a lot of her diffuse symptomatology. Although they found multiple endometrial tissues in the, I believe, small bowel.
What was the age? Sorry, I missed that.
31.
31.
Mhm.
Is she on any hormonal treatments for the endometriosis?
I have to go back. She was previously on Larin, but I'd have to double check because I think she was stopped with her gynecologist from that.
And then did you order like the mast cell labs?
Yes, her tryptase has been persistently normal. They're kind of a more random levels,
Mm-hmm.
but also when she's been experiencing significant symptoms. Immunoglobulin levels have been normal.
Okay. Yeah. And for the small fiber neuropathy, kind of the gabapentin is the only treatment.
Yeah, we've discussed certainly trialing duloxetine, nortriptyline, but I think she has a lot of hesitation with the psychotropic medications and sensitivity. So I think she tolerates it at night and doesn't experience the side effects in the morning, but that means her neuropathic pain is usually pretty bad during the day when she does not take it.
And then outside of the ANA panel, did you check anything else? Like some of the times the neurologic antibodies are different than like what the traditional ANA ones get. Or maybe the neurologist drew that.
Yes, we've gone full bore. She certainly has this flavor, being a 30-year-old woman of an autoimmune dysfunction, positive ANA. We have found a significant portion of our patients have anti-ganglioside antibodies. She does not. We tested the GCPR, the full dysautonomia paraneoplastic panel, which was all negative. So we've not found a specific autoantibody target, but if there are specific ones, chances are we've done it, but I'm all ears.
And they've all been blood, not any CSF.
We have not drawn CSF on her.
And I guess that's my question for Gabe. Which ones do you get LPs and get CSF for?
Not in this age group.
Not in this age group? Oh.
No, I mean, we really don't have any support to do that. Although I was thinking the same thing. I mean, I'm surprised you didn't do it because out of desperation, one ends up doing things that maybe not necessarily supported by empirical evidence. But no, I mean, unless they are, given our data now, unless they have at least 55 years of age and some evidence of neurological decline, I don't do it, please.
Thank you. Dr. Sabat, do you have a?
Yeah,
Mhm.
so just from a patient management standpoint, are you her primary care doc also?
No, I am not I don't have a primary care clinic, so
Okay.
I am her primary care doc, but I'm not.
Yeah, I was wondering like how often she's being seen and how many referrals do you have going on and all that stuff.
Yeah, unfortunately, for her, it has been difficult. There were periods throughout this year, given her age, she was uninsured, on Medicaid, on county insurance. And then now was actually, that's kind of identifying. She now has stable HA coverage. And so, unfortunately, her care has been a lot more fragmented by her insurance status, although at least our clinic accepts everything. So we've been able to continue to see her. But some of these subspecialties, which for you guys, UT Health Austin is a little bit of a smaller clinic system. We don't have all the specialists. She's had to see outside.
I will add a little, so mast cell-like disorder, definitely she meets a lot of the criteria, and it sometimes comes in that patient population, but endometriosis, mast cells are key players in endometriosis. And so they can release inflammatory mediators that drive like pain, inflammation, and those types of things. So I do wonder if like, can she tolerate, or has she tried any kind of mast cell protocol just to help with symptomatology for everything?
Yeah, that's a good question. And if there are other experts on there, we trialed it and kind of the typical cetirizine once daily, twice daily, 4 weeks, and briefly did a trial of cromolyn, which did not really help her GI symptoms. I do think I have her seeing a immunologist who I have less experience with, but at least in Central Texas, advertises experience with mast cell activation. And I'm interested. I've always kind of said like the more biologic, Xolair or some of these more advanced treatments, I would certainly support. But I think that's been limited a little bit by cost and not quite meeting any criteria that I think insurance would pay for.
Is there anything? So sometimes there are, I feel like, some rheumatologists who are more flexible and they feel like, do someone have a flavor of like neurosjogren's or and then they're willing to treat them and start with
Not
something
very many.
autoimmune. Right.
I've not found a rheumatologist who's willing to go off book as much as I would hope, especially I think as we're waiting a lot of these preliminary trials about immunomodulators. I think some will give hydroxychloroquine. I've even advocated that directly to her rheumatologist, who strongly felt that was not indicated. I know the baricitinib, I think it's tough. I requested unblinding from her IVIG since she did have some preliminary benefit from that. Although I don't think they will unblind it until the study is completed, so May at a minimum.
Well, thank you very much. And for protect everyone's time, thank you so much, Dr. Broad, for this very interesting case. And we're gonna go to ask Dr. Monica Verduzco for the recommendations. But before that, I would like to ask you if you, in the future, consider present a follow-up of this case. Please present a case again to see how it has been managed and how is the outcome that we would like to hear from that case. And also invite everyone in the audience, if you have a real life case presentation, please join us and consider present the case in a future session. So Dr. Verduzco, would you please provide? Yes.
Maybe,
yes.
Dr. Verduzco, I'll make it a little bit easier on you. I think my main questions, I think this is one of my most challenging cases, and I really want to help her. I'm a little bit on the fence of, do we really, she has a couple things. Do I follow more of a POTS-centric pathway for symptomatic control, mast cell activation, to try to get her potentially more advanced regimen or access to the biologic therapies? Or do you think, as you said, she has as I think, some of this autoimmune flavor to either try to enroll her in a clinical trial or get her to a rheumatologist who would play ball to try things?
Yeah, I think the answer for you is all of the above. That can be the answer, because I feel like some patients with POTS and dysautonomia, that is only better managed if they have their mast cells managed, because that will like flare their autonomic dysfunction. So sometimes that is like the mainstay of managing their POTS. And then also, I do agree that it's definitely an autoimmune flavor, especially, the ANA, and maybe we're just not finding it at the right time, the right antibody, the right, type of thing. So yeah, still trying to find that kind of rheumatologic treatment that might help.
Dr. Erowski, do you have a comment in the chat? Do you would like to elaborate a little bit more?
I wonder if Monica, have you tried avapritinib on any of these patients? You know, it's whatever the name is. I never know how to pronounce these commercial names. Avakit, I think they call it.
Oh,
It's approved for mast cells syndromes, and it's a pill. The problem is that getting any of these drugs approved by insurance is always a problem. But
right.
at some point, I actually reached out to the company to see if they were interested in doing a trial in long COVID, but they shut me down.
Yeah, I wonder if the medication is like on cost plus pharmacy, and then it might just be easier to get to the.
No, this is an antibody, so yeah.
Oh, yeah, okay.
Yeah.
Yeah. We're not so lucky.
No.
Is there another comment, Dr. Verduzco?
No, I just think, there's some of these challenging ones who you try to
Yeah.
help, and Avibradine, have you done that yet?
Yes, that's going to be what we were considering next. And now that is $40 on cost plus, I have started to utilize that very quickly.
Mhm.
At $1,000 in only being allowed to be prescribed by cardiologists, it was tough, but I've really embraced it at $40.
Yeah, so I think, go the Avibradine route and see if you can like circle back to the mast cells again.
I like that.
Yeah, and again, if you consider present a follow-up of this case, I think it will be a very good opportunity, Dr. Brock. It is a very, very interesting case, and I extend this invitation to everyone that joined our session today that please consider present a case. So, as I always said, the ECHO is all learn, all teach environment. So we all learning in this opportunity. There is a couple of messages in the chat. Please, if you're interested in presenting the case, the information is there. Also, to learn a continuing education credits, please complete the survey. This is gonna be open or closed on Tuesday, 1/13 at 12, and the certificates as well. Well, thank you so much for joining us our session today, and I hope to join us next month. Until then, you have a wonderful time and a wonderful day. Thank you so much
Thank
again.
you.
Thank you very much.